We just started recording, so you have to excuse me. We'll have to repeat what we said. Today we're going to talk about a 75-year-old grandfather who's now 81 with very complex heart disease and a 6-year follow-up. And we want to see, have we added value to the case? And so the question nowadays, as we prepare to move from fee-for-service to a more value-based care, such as perhaps a bundled product, as we move to greater communication among our coworkers in terms of patient care, there's going to be certainly a reduction of at least 5% in payments, and what we have to show is efficiency and increased quality. And so in order to actually save more money than that. And so it's about quality, which is value. Quality per dollar makes value. And so we're trying to make that transition. I'm going to welcome Largo Medical Center. Welcome. So we're going to try to make that transition, and so we're going to talk to you about how this patient was managed and whether we were successful or not. And so let's take a look at that and see what we got here. And hang on please for a minute. Let's see if we've got our upgraded slides. Yeah, we got them. Okay, they came over. So let's talk about our gentleman who represents a new kind of patient that we see that's much more sophisticated than what we've seen before, and I'm seeing more and more people like this, and so it's good to know about this particular kind of patient sort of as a model. And so he was 75 when I first encountered him. Caucasian, married male, was a physics major in college, which is kind of interesting when it comes to my explaining things to him. He understands the physics that's involved in coronary artery disease. And he was originally from Jacksonville, moved to Tampa. He's a real estate developer, restaurateur, businessman, and his complaint was dyspnea exertion and chest pain. And being in the social circle that he moves, he was basically referred to the social circle hospital at the time, which was St. Joseph's Hospital, where he had a cardiac cath by a very good physician, and who, by the eyeball test, this was prior to FFR, basically referred him for coronary bypass grafting for multi-vessel disease. Patient quickly declined and has an extensive network, and got on the phone. Whenever I see him, he's always on the phone, and that's how you have a network. And so he got on the phone. He's on the board of Shands, so he talked to Shands, penetrated cardiology, was given a cardiac interventionalist, and looked up his experience and found that he didn't reach the experience level that he was looking for. So he had a nephew that works for Boston Scientific, which is a stent and catheter company, and he was in the Far East Division in Hong Kong, and so he called him, and he basically got him in touch with other Boston Scientific doctors, and we'll have to edit this if it'll edit. Won't edit, but anyway, managers, and the manager that he got in touch with referred him to Dr. Philip Stromquist because he sells the catheters in all the hospitals, and said he was the best. And so I'm not going to dispute that because I worked with Dr. Stromquist for years at Tampa General, and now he's at the VA hospital, and he is very innovative and certainly keeps up with all the different catheter changes and different stent changes. So let's see what happened after that. And this is his history. And I took his history and sort of linked it to congestive heart failure incidents given these kind of symptoms, just to show you that he is at higher risk of developing congestive heart failure. And so this is kind of like a typical cardiac patient that we see nowadays in this age group. He has a list of diagnoses here that maybe 12 or 15. Some of our patients have 50, and yet they're walking and talking and somehow compensate with all the problems that they have. And so he has insulin-dependent diabetes mellitus, and of course, that's a risk factor for myocardial fibrosis, microvascular changes, large coronary artery disease, as well as congestive heart failure, diastolic dysfunction. And so his creatinine is okay. It's 1, and so he doesn't have a serum creatinine risk, but all my patients seem to have high BMIs, and so he's a round one, and his BMI is 33, and greater than 30 is a risk for congestive heart failure. And you can see when I took him on in practice 6 years ago, he weighed 220, and with my multiple efforts to get him to avoid white foods such as rice, pasta, which he loves, and potatoes, and my effort to decrease his wine consumption, you can see that I'm a failure in terms of weight reduction because he's actually gained weight. And even after visiting Dr. Gould in Houston and being chastised by him, he still continues to maintain his lifestyle. And so you'll find that a lot of the patients that you see are coming to you so they can maintain their lifestyle. They really don't want to change. They say, give me a pill or give me surgery and I'll be happy because I like the way I live. This gentleman now invokes the 81 rule. He says if you're 81 years old, you can do what you want to. You know, you can have dessert, you can watch TV, you can get up and snack at night, you can do whatever you want because you're 81 years old. And so such a contrast from Dr. Gould himself, who eats like a mouse with very little food and exercises every day. But I don't think he got his attention. I think he thinks of him as a tall, skinny fellow. And so we have basically hypertension with severe LVH. Well, this in itself is a separate disease that can be very difficult to manage. And with severe LVH, there's a problem filling the left ventricle. There's a trade-off in terms of muscle-bound heart that doesn't have much of a cavity anymore. There's a diastolic filling problem. There's a decreased elasticity. And so the hypertension in itself creates a problem, and the LVH creates a separate problem. And then the diabetes creates many problems in terms of the body just gradually rusting. And then the BMI creates a lot of problems. And then the coronary artery disease history creates a lot of problems. So we certainly have plenty of reasons for this gentleman to be short of breath. And so, and the sleep apnea with no CPAP. Well, where is the CPAP? Well, it's on the foot of my bed. It's on the bedpost. That's where I keep it. You know, you ever take it off? No, I just leave it there. I know where it is. And so, and then the pneumonia, GERD, BPH, hypothyroidism, cigarette smoking remotely, and these are the kind of things, vein stripping, these are the kind of things that we see in this age patient. And so let's take a look at our next slide. Well, wow, what's the difference between these two hearts? Well, one is humongous and the other is small. Well, these are specimens that are in the pathology lab, and you can see they're kind of shrunk because they've had formalin. This is not an active heart that relaxes and fills. Neither is this one, but you can compare and contrast the two, and you find you can't see the cavity much here because, you know, it's been preserved. You can see the right ventricular cavity. Look how big this heart is, how thick it is. Think about it getting so thick that it's outgrowing its blood supply. Certainly we have to have deep penetrating septal perforators coming in here, and there's a lot of septum to perfuse, and perhaps we have some Thebesian veins that's on the surface endocardial and giving some oxygen as well. But you can see that there can be an increased perfusion gradient and also diffusion gradient for oxygen And it's really hard to oxygenate a heart that's muscle bound like this. It's also hard to fill it, and it doesn't have any trouble squeezing, as we'll show you here in a minute. So we have things that can be happening. We've got increased intramyocardial pressure. We've got, and hang on here, let me move this over. We've got some decreased aortic elasticity, which is responsible for propelling the blood forward. The elasticity of the aorta is very much responsible not only for the heart muscle pushing the blood forward, but for this elastic aorta also pushing the blood forward. And so there's a lot more work because of that. There's increased peripheral vascular resistance, decreased compliance, decreased elasticity, increased stiffness, and so this heart eventually starts becoming fibrotic, has more collagen expression. You can see the fibroblast and fibrins deposited, fibrosis, and you can't see that. It's just this muscle is a thick muscle, and you say, well, that's a thick muscle, but it may not be a thick muscle. Really, it's muscle, fibrous tissue, collagen, fibroblast, interstitial volume, interstitial edema. And so to make this muscle thick, there's a lot of components going into this. And so it may not be just a thick muscle, it's a thick myocardium with multiple components. And so leading to some physiological changes that are extreme. So in this gentleman, we're going to have to consider that he has a muscle that's going to have a lot of problems pumping his increased volume as a person who is over a BMI of 30. Let's look at some of the things that might be happening here with just hypertension alone. So hypertension is a significant risk factor for developing coronary artery disease, and the patients that I have with hypertension that I follow up on inevitably develop coronary artery disease. You can just, despite all my efforts and blood pressure control, they inevitably, over a 20-year period or 30-year period, will develop coronary artery disease, even with statins and all the stuff I'm doing. And so that's an inevitability. And then we've got left ventricular hypertrophy, failure of relaxation, decreased compliance, and so again, diastolic dysfunction, which leads to increased left ventricular end-diastolic pressure and shortness of breath when you're walking and doing stuff. Not at rest, but certainly during activity, decreased stroke volume. And then a risk factor for the left atrium dilates above the chamber that's thickened because blood isn't flowing in very well because of the decreased compliance. So this chamber starts dilating and stretching. These are the pulmonary veins, left atrium. As that happens, there's a predisposition to developing atrial fibrillation. You can have stasis of blood, left atrial velocity, left atrial appendage flow velocity decreases from 75 centimeters per minute to perhaps 12 centimeters per minute. And so that causes an increased risk of clot and stroke. And then there's a prothrombotic state. There's some inflammation over here as well, cerebral vascular disease. And so these are the things that I have to fight. And this is a formidable opponent in a 75-year-old gentleman, getting him to 81. And so there are ways that we can look at this myocardium and understand what's going on. And we have new techniques that I want to tell you about, because we're going to tear our magnet down and rebuild it with all new stuff. And one of the new modalities we will have will be T1, which is modified look locker sequence called Molli. And this can tell us about this myocardial interstitial space. We can see amyloid, we can see certainly deposits of substance in Fabry's disease, in sarcoid, we can see non-caseating granuloma. In hemochromatosis, you can find iron. And so we got edema, which is usually more of an acute problem, separating the myocardial myofibrils, and we got fibrosis, which is in the interstitial space between the muscle fibers, and we have deposits of stuff. And so all of this can be told by doing a picture with this called T1 relaxation, and basically looking at that and visualizing the T1 relaxation. And so let's talk about, we're going to have this upgrade in our magnet so that we have a new repertoire, and it looks like we can use gadolinium, which is pretty harmless unless you have severe renal dysfunction and you're on dialysis. And we use very small amounts, as you can see, and we're able to, within a reasonable period of time, which we've got 30 to 35 minutes, so this is a specialty item, because if we're evaluating someone for chest pain in the ER, our whole procedure and all of our sequences actually take about 30 minutes. And so this is an aside specialty item that we'll be able to provide to analyze for fibrosis of the myocardium or for edema. And so we think this is very important, and we'll show you more. That's why we explain it to you, because it's going to be important for us to have this information in the future. And so let's see what we're looking for. And so this is the cardiomyocyte. There's some little drops of water in here that are these little blue things, and there's collagen fibers that bring it all together, give it structure, and make it have some firmness to it and not just be floppy muscle. And so as that happens, people can be like this, which is normal, where they have very little separation of the myofibrils, and therefore just a little bit of water in here, and the water is influenced, of course, by our magnet sequences in terms of the protons involved there. When we stimulate them in a magnetic field and then apply another magnetic pulse, we're able to cause these protons in the water to go to a different state of spin. And after they get that different spin, that's not a natural state, and there will be a relaxation or a falling back to an old spin pattern. And there are two times that we can measure that are involved in the falling back. T1, and it drops back to a previous state, and then T2, it goes back to the resting state. So we've got this in a magnetic field inside a magnet, and then we're setting off a magnetic pulse, and that magnetic pulse then is stimulating these protons in water in a magnetic field to change their spin and their spin axis. And that's a temporary state because we put a temporary pulse in. And as they change their state, then there's going to be a tendency for entropy, which will mean they will drop back to their previous physiological state. And the time it takes to drop back are 2 units of time, one being T1 and the other being designated as T2. And so now we have a way of measuring what's happening there by those times in the magnetic field when we make our pictures from these changes. And so if you have edema, we can measure that because we're going to have a lot more protons that we're stimulating, and it's going to make a big change in terms of the T1 time, a recovery from the state that we created with our pulse and in the electromagnetic field. And so we'll measure that T1, and edema will look like this. This is the change, the myocardium, and the change over time as it falls back to its previous position, T1 and then T2. So we're able to measure these things and see where we are on this curve. And then we're able to see what the normal is, which is the black line. And then if there's a lot of collagen, which are these little blue fibers in here, and you see we have also edema and collagen. If there's a lot of collagen in there, there will be a different relaxation time that takes place, which is the line number 2. So we got these lines. We can measure these particular positions on the curve. We can establish from here to here, so we got 2 points. From here to here, we have 2 points. And from here to here, we have 2 points. All we need are 2 points to establish this line. We establish this line, we can tell you how much interstitial fibrosis is there. We establish this line, we can tell you how much edema or water is there. And then we can translate that into a picture using the myocardium as we visualized it. So given that concept, let's take a look and see how this moves on. So here's what's happening. Here's a normal myocardium. Haven't given any contrast yet. We inject gadolinium. It goes into the blood pool. Gadolinium is spinning around. Some gadolinium will penetrate from the blood pool into the myocardium by perfusion and by the Vesian veins. And so here's the gadolinium coming out of the capillaries and getting stuck in here. And then we make a picture of it because it's kind of stuck in here. And we get a nice picture. And then it's excreted by the kidneys. And so on the other hand, we're over here and we've got the myocardium and the myocytes, and they seem to be a lot further apart. And so the thickness of the left ventricle is not from muscular hypertrophy in this case. In this case, it's from fibrosis. So the hypertrophied muscle has actually atrophied, had some apoptosis, and you see there's less myocytes, and has transitioned to collagen. And so we have interstitial collagen, and then they call it extracellular matrix, which is other stuff that's in there. And so when we make this picture, it's going to be a little bit different. We're going to have the gadolinium is all going to go in here. And we're going to have, look, so much more gadolinium because gadolinium goes in the interstitial space and likes it there. So it goes from the blood pool into the interstitial space, and more gadolinium is going to be there, and that's going to change the relaxation time. And so we'll be able to measure that and make a picture off of it. And so let's take another look and see how this is happening. And so, well, here's another case where we've stained for collagen. And this is a myocardial biopsy. And this is a stained collagen in a normal patient. And you can see the red is the, like Congo red, is the stain that it takes up in the color coding. And then here's a patient with aortic stenosis. And this patient must have had aortic stenosis for a long time. And you say, well, this is a very thick ventricle, and he's got left ventricular hypertrophy. Well, it's more than just left ventricular hypertrophy. It's left ventricular interstitial fibrosis. Well, this doesn't relax well. If we put a new valve in, this muscle is going to be under less stress, and it's going to beat better, but this isn't going to beat better. This is actually not going to beat at all, and so we've got a bunch of stuff in between the myocardial cells that's going to be counterproductive in terms of increasing contractility. And so we need to know that. There are patients that have low gradient, low cardiac output, end-stage aortic stenosis that we might be considering a TAVR on, or we might be considering aortic surgical valve replacement. And afterwards, we may wonder, why isn't this patient doing better? And we have that. As a matter of fact, the TAVRs in patients who have severe aortic stenosis with a low gradient, that would be like a 20 millimeter gradient or 30 millimeter gradient, with a low cardiac output, don't do well post-TAVR. Well, I guess at Northside we've done about 25 TAVRs now, and they've all been a huge success. There's only been a few little complications in terms of arterial access vessels, and there's not been any strokes or deaths. But we've chosen our patients well, and we've not chosen one of these. And if we choose one of these, we can expect less success in terms of increased cardiac output post-valve replacement. So having a way of identifying that this is not just hypertrophied muscle, that a bunch of it has been replaced by collagen, will be very important in basically determining which patients should be having a TAVR. And the thing about the TAVR is you have a learning curve. The first 25 TAVR is great. Glad we got over those. Then there's going to be another 25, another 25, another 25 to get to 100, and that's the learning curve. And so we have to succeed on this learning curve, and we don't want to pick this kind of patient for the first 25 because we're going to fail. So if we pick 12 of these to start with, we're in big trouble. We picked the wrong guys. And so to be able to identify this and to quantify it and then have some predictability with a score based on the fibrosis of who's going to be a successful TAVR will be very important to us, because that's a lot of resources that we have that we're putting in place for this patient, and we're not going to get value if he doesn't make it through it, or if he has the same cardiac output when we get done as what he had before. When else can we use this? Well, quantifying fibrosis in patients with left ventricular hypertrophy is very important, and that's what we have here with this patient. And I just want to show you a little bit about the process. We're making images. The images are after the injection of gadolinium, and we're plotting curves of that T1, or relaxation time, and you saw where we had 2 points. Well, here we got a lot of points, and these are the curves we're plotting in terms of these points on the line. And what we're talking about is the myocardium, and you can see, this left ventricular cavity, this is the right ventricular cavity, this is the septum, lateral wall, anterior wall, inferior wall, and what we're trying to do is we're trying to quantify, we leave the papillary muscles out of this, we're trying to quantify this zone, okay? And we're trying to characterize endocardium and epicardium, and then quantify the stuff that's in between. And you can see, and then we do that on a series of slices, and then we do that over time so that we can map these T1 relaxation times after stimulation externally with a pulse inside a magnetic field. And so that's a very small area subject to error, and that's where we have to make careful decisions when we do this in terms of training ourselves and training our fellows. And so here's an example that has been color-coded to show you someone who has a very thick left ventricular septum and a thick apex. And this is interesting because we have some muscle that supposedly is kind of normal, and then we have muscle that is hypertrophied because of genetics. And this is an inherited disease, or it can be a spontaneous mutation, many times an inherited disease, and the hypertrophy is localized, and that's localized in the septum, and this is the interventricular septum, and there's some here at the apex, and we're able to see with T1 relaxation time and color coding in a 3D volume picture, we're able to see characterization of the fibrosis in the septum and the apex in this patient who has this very peculiar disease of septal hypertrophy and apical hypertrophy over lateral wall and inferior wall, which hasn't hypertrophied at all. And this is a selective disease that is involving those areas mostly. It can involve lateral wall and not the septum. They're all different deviations of this particular disease. But look how nice it can be characterized and how you can see how much fibrosis it is. That's very important in predicting how this patient is going to do, as well as predicting arrhythmias, because this is a better setup when there's dispersion of myofibrils and there's delay of conduction of impulses. That gives you an opportunity for reentry, where a Purkinje fiber can fire as a PVC, and that PVC then can migrate through the myocardium in depolarization, and then by the time it gets through all this fibrosis and comes back around, this side is repolarized again, and so then we can get a circular ventricular tachycardia set up because of the difference in conductivity of the myocardium and the fibrotic interstitial stretched myocardium. And so we set up a macro reentry circuit, and that's called ventricular tachycardia, which can lead to ventricular fibrillation and sudden death. So we're very, very concerned about identifying septal fibrosis with some kind of gadolinium enhancement, and this is one way of doing that. So very important, this patient might be such a setup that we would be monitoring them. We might consider an ICD in this patient because of the amount of fibrosis and the setup for ventricular tachycardia. Let's take a look at color coding fibrosis. And so it's possible to plot the T1 recovery time of these little protons of water that have been stimulated in a magnetic field by a pulse wave of magnetism, which then they have to relax. And so you can measure this relaxation T1 time over time with these images, and then you can color code muscle and distinguish muscle from color coding fibrosis, and which is a different response in terms of T1 relaxation than the muscle, and you differentiate that by color coding. And so then we have pretty images that can show us fibrosis, and then we can quantify it off of this curve. So very important in terms of deciding what's going on in this ventricle and why isn't it working. Well, the use of T1, as I demonstrated, is useful in cardiomyopathy, hypertrophic or dilated cardiomyopathy, aortic stenosis, especially late stage when there's a low gradient and low cardiac output, cardio-oncology on patients who've been exposed to adriamycin, or radiation therapy to the left breast and exposure to the heart, and left ventricular hypertrophy, which is so common because of hypertension. Back to our patient. So let's talk about this gentleman and how he's being treated. And so our job is to keep him out of the hospital. Our job is to maintain quality of life and lifestyle. He wants to continue his business. He has trips to his home in North Carolina. He's the advisor of everybody in his family and others. He's on the board of many businesses. We also have the responsibility to society of saving medical spending, of giving the patient some kind of medical security that he feels that there's a net, that he can make these trips and to do no harm. His survival is very important to him, but maintaining his lifestyle, as well as continuing to eat what he eats and drink what he drinks and maintain a BMI greater than 30 is important to him too. And not having disability when he's in the mountains, he wants to be able to walk on the golf course. Wow, that's tough. So we've got diabetes, giving a stiff ventricle, microvascular changes, as well as large vessel atherosclerosis, and this is what he's on for that. This is insulin-dependent diabetes. Hypertension, man, controlling his hypertension, there's a problem with a gentleman who seems to have very resistant hypertension. Look at all the stuff he's on. He's on Coreg 25 BID. That's slowing down his heart rate. That's going to favor an extended length of time for diastolic filling. So the heart's going to have more opportunity for this inelastic, non-compliant left ventricular cavity to get the amount of blood it needs and then expel it. It's going to have more time to do that. And that's important because per unit of volume, there's a greater increase in pressure resisting filling. And so we got Coreg to slow his heart down. We got Tecturna that's operating at the kidney level. We've got nifedipine, that's a vasodilator, lowering blood pressure. Tirosicin, which can act in several ways, as Hytrin is an anti-hypertensive as well as for BPH. Minoxidil is a big gun, and so it's a drug that we only use in the most resistant cases of hypertension. It increases the heart rate, so we got Coronary to block that. It also causes fluid retention, something we don't want. So we got furosemide to decrease the fluid retention. We also got indapamide to do the same thing. We've got potassium to replace the potassium he's losing. And then one time we decided, well, let's try him on a new drug not intended for hypertension in this country, but for congestive heart failure. Why don't we try him on Subotril, valsartan, which is a new combination drug called Entresto. Why don't we try him on that and see how he does on that? So that is used in Europe frequently for hypertension and can be helpful. It's BNP, or at least it raises the BNP by slowing the metabolism of BNP. So we did try that. And we tried him off the beta blocker too, because we thought, well, maybe he can't increase his heart rate as he would like to when he exercises, and maybe also because he has some peak expiratory flow that's decreased in his pulmonary function, and some maybe bronchospasm, that maybe he'll do better off of a beta blocker. Well, it really didn't work out, and he really needs that slow heart rate to be able to fill his heart. He needs to have the diastolic time for diastolic filling. So that didn't work out. So we stopped that, and we put him back on his beta blocker. And so he's on Crestor, fenofibrate for his triglycerides, aspirin, ranolazine, which is a late sodium channel blocker that basically is an anti-anginal, anti-ischemic drug. And so all these things, very complicated, and then he has hypothyroidism. So in 2010, which was the time we talked about, and he shopped around among many people, he wound up going to Dr. Stromquist, he had his cath already at St. Joe's, so they put some stents in the proximal LAD, which was the only significant lesion identified by Dr. Stromquist, and the gentleman was, billed as multi-vessel coronary artery disease and was supposed to get bypass surgery. So bypass surgery could have been devastating to this gentleman, given post-operative hypertension, the blood volume changes, that we stop all the medications and then start all over again. And so a possibility of stroke, with cannulation of the aorta and being on the heart-lung machine and getting pump head. So fraught with problems. It's a roulette wheel. We spin the wheel when we take the chances on open heart surgery. You never know what the outcome's going to be. And he had the stent had a diagonal coming off the side, and so you do the kissing wire and you put a wire in each one, and this large jailed diagonal couldn't be stented, and it was kind of left there sort of isolated as a problem. And then he's put on Plavix. So we got that problem, and there's main left disease. This is a new problem, 50 to 70% main left disease. I need to know how much that is. 70%, whoa, that's a surgical candidate. 50%, we manage medically all the time. The difference of 20% can be huge. And so here he is, I'm following him. He's got chest pain. He's got shortness of breath off and on. He has it at night. He has sleep apnea. He's got hypertensive episodes where his blood pressure goes up to 180 systolic. He's got fatigue. How am I going to follow this gentleman over a 6-year period, keep him out of the hospital, maintain a quality of life, and decrease the expense that's spent on him, which is the challenge of CMS with new value-based practice? And so I decided we'll do cardiac PET, echo, and CT. This will be the way that I will follow him. Innocuous test, cheap test really, in terms of this is the same cost as a SPECT scan, but much more sensitive and specific. And echoes right in the office and takes about 15 minutes. Cardiac CT, 10-minute prep time, 10-minute acquisition time. We got coronary arteries It's replacing cardiac cath in many ways. And then he didn't want MRIs because he's claustrophobic, so I'm not going to get a T1 relaxation time, unfortunately, but we'll have that in the future. Objectives, these are my objectives. And so here's what happened. During 6 years, he had 2 days overnight in the hospital and 1 ER visit. I think that's a pretty formidable record given all the stuff this guy has. So I spent some money on PETs, and I spent some money, which is the color-coded, the dark blue here. I got 3 of those. So I spent some money on CTs, and I've got 4 of those, you know. And we spent money on 1 cardiac cath with the stent, which he had, which I'm not including in this tabulation. You know, 1 cardiac cath at St. Joe, and then the stent at Tampa General. So I submit this record as being a pretty good record for someone who has frequent shortness of breath, dyspnea on exertion, chest pain, sleep apnea, diabetes, and left ventricular hypertrophy, and is on the verge of congestive heart failure at any time, and also has on his EKG a conduction defect with first-degree AV block, left main disease of 50%, and a distal circumflex. And so he's got first-degree AV block, right bundle branch block, and left anterior fascicular block. So he could actually go into complete heart block at some time, and undoubtedly would develop congestive heart failure if he did that, and would be in big trouble. Most people in complete heart block have a heart rate of about 36, and they just call up and say, hey, you know, I don't feel so good. I'm a little tired. They don't have sudden death. They just have complete heart block. You got lots of time to do stuff. They come over to the office and you pick it up on the EKG. This guy would definitely go into congestive heart failure and would be an extremist if he developed a heart rate of 36 with complete heart block without having this atrial ventricular sequence of the atrial kick and then filling the ventricle, because he really needs that. That probably contributes 20% of his cardiac output with the atrial kick. So here's his EKG. It's kind of fuzzy. I'm sorry, we'll have to have a better way of producing these, but you can see the gist of it. And the gist is he has a terminal conduction delay, which is right bundle branch block, a QRS duration of greater than 120 milliseconds. He's got a left axis that's minus 60 or 70 degrees, and then he's got a normal sinus rhythm, and there's a first degree AV block. So I just wanted to show you vaguely what it looks like. And then, so let's talk about how we're going to follow this patient and how this is going to help me. So I'm going to follow him with PET scans. What's the advantage of a PET scan? Why don't we just do the old SPECT scan? Well, we have some advantage in terms of, one, the positron, when it encounters an electron, basically gives off a gamma ray, 2 of them, in opposite directions, about 180 degrees, and the gamma ray is very powerful. It's 511 keV. Well, what's that mean? Well, that means it'll go through me, it'll go through the wall, and it'll be on its way out there. That's why you have to have a lead in the wall. And so that's very powerful energy on the move. So, well, okay, that's going to make better pictures. It's going to make a stronger impact on these sensors in terms of, as opposed to 140 keV of technetium. And what's going to happen is we have these 2 emissions simultaneously. That means at the same time we have negative matter impacting with positive matter, causing annihilation, and 2 gamma rays, and they're 180 degrees apart, which means there will be synchronicity on the sensor. And synchronous events will occur anytime this happens, and these gamma rays are given off 180 degrees apart. So if we have this sensor set to only pick up and register stuff that's occurring 180 degrees from each other, here and here, or here and here, and here and here, then we'll solve the problem of fuzzy images from Compton scatter. Because there's a lot of stuff going on here. We're looking at the most pure part, but there's a lot of stuff going on when we got isotopes in somebody, and there are rays zigzagging all over the place in here. that are not related to this event, but that are related to secondary events. It's called scatter, Compton effect, and that basically is impacting the sensor everywhere, but not 180 degrees apart except by coincidence once in a while. And so if we separate out these events and get rid of the others and not register them, we have a screen, we have a filter, and then we'll have a pure picture that won't be fuzzy. And we'll have a bright picture because we've got 511 keV rather than 140. So then we have these images though, and one of the things that you see here is this gamma ray is passing through the body all the way through this part of the body till it gets here. So it's going to lose energy on the way. And so it's going to be less energetic when it gets here. And so it's going to be less, let's call it less bright. And this one, which is part of this event, which is in the heart's eccentric in the body, is traveling in the opposite direction, 180 degrees, opposite direction, and it's going to be very bright because it's not losing energy as it travels through the body. So this is going to be bright, and this is going to be not so bright. But how are we going to adjust for that? Because this not so bright may look like decreased counts, and you might say, ooh, there's something wrong with that side of the heart. It's got less isotope, and there are decreased counts there. But it's not. It just had to traverse the body. Well, that's the problem, and that's called attenuation, and you have to correct for that. And the only way to correct for that in a reasonable way is to know every little thickness of this body and have that actually in a supercomputer that can tell you the thickness it had to go through here. And so then that's going to decrease the brightness, and so you've got to then turn up the brightness to compensate for it. And then the distance and the thickness in Hounsfield units it has to travel through here, which is going to be, it's going to be very bright, and to normalize that, you'll have to turn down the brightness because it'll look like it has more isotope coming through there. So we turn this one down, we turn this one up, and we do that on all of these that are coming across based on the thickness of the body and the structures that it's traversing. If it's going through the lung, less attenuation, okay, more brightness. If it's going through bone, say it went through this arm, coming through here, through this arm, it's going to lose brightness and be dull, and so we'll have to turn it up to compensate for having gone through an arm. And so that's the purpose of two donuts. One donut is the PET scanner. The other donut is the CT scanner. And this is the PET, and this is the CT. And so the patient traverses through here, gets a PET, gets a CT. The CT is used for correcting for every one of these events that occurs. It can correct it. So we've got, this is just looking at the PET and pure PET. This is looking at CT and pure CT. And this is where we make the adjustment based on every little area of decreased radiation by bone or less decrease in radiation by air and lung. Every area is adjusted to make this picture. And so this is a corrected picture for attenuation. It's called attenuation correction. And so this is the gadolinium picture, this is the CT picture, and this is the correction. So we showed you three things that are very important in distinguishing PET from SPECT and making it better images. 511 keV versus 140 keV. That's power and brightness and penetration of the gamma ray. Attenuation correction with the CT scan and the PET scan. Coincidental counts. That means simultaneous activation of these sensors basically, and not counting the Compton scatter, which makes fuzzy images, makes much more defined images. We drop the others and get rid of them and don't make the image with them. And so, and we basically can do a lot of things with these images in terms of measuring coronary flow reserve, absolute myocardial blood flow. We can tell things that you could only tell experimentally in the lab on animals in the past. So that's very, very important in knowing how to use this. And so let's go to next slide. And so here are the images. And this is the same gentleman we're talking about. And this is what's happened to his myocardial flow. And he actually has kind of a gradient of decreased myocardial flow because it's basically at the end of the artery because of diffuse coronary disease and not having a focal blockage that we're able to see what's happening and the decreased flow that he's getting. And so it's because there's a diffuse gradient of attenuation of blood flow that's occurring, not a focal blockage, but atherosclerosis throughout the vessel. And so, and that's what makes these pictures, and that what makes these pictures important. And so let's show some CT scans that we got on this gentleman. Here's his blood pressure. We finally got his blood pressure in control. There's no way you could do that without a 24-hour blood pressure monitor. And so here's a 24-hour blood pressure monitor. This is about 180 here, and you can see way out of control. It took minoxidil, took some very powerful drugs to get him back into control. And here's the CT that we're using, and we actually can use the CT for evaluation of his left ventricle. And we can actually watch contractility, meet these objectives, and he lives a better life. So let's show you how we did this. Okay. And so we will come down here, and we'll show you some of the images that we have that have helped us make these decisions. And so I'm going to show you this set of images, which you've never seen this on this particular show. I've never showed you how we can actually do myocardial contractility, because we don't do this on people that we're screening for coronary artery disease, because it takes a lot more radiation. Because what we're seeing here are basically all the different volumes that we've acquired during the cardiac cycle. So we'll acquire pictures at 10% between the two QRS markers. So 10%, 20%, 30%, and that's the intervals between the EKG as markers, which is called gating. And so we're able to acquire that if we really need that data. And so we're going to show you how we put that together when we felt like we really needed that data. That requires a lot more radiation. And so it's instead of less than 3 millisieverts, we might have something like 20 millisieverts. But in certain instances, it's useful, and certainly it can tell us stuff about the state of this heart in terms of volume, contractility, relaxation. Of course, we can find out some of these same things, and we're going to bring this up for you here. Hang on. We can find out some of these same things when we do echocardiogram as well. Let's pick an image. Let's pick this one. And let's show you, let's pick how we're going to make this move, because we got to have ways of making this move. And so let's show you, as we go through these sequences of systole and diastole, we are able to produce a beating heart. And so, and then we can enhance that. You can see how grainy the images are sometimes because of his body habitus of BMI greater than 30. And we can slow this down a little bit so you can better see it. We can change the color coding if we need to. We can very well show you these images in a 3D volume picture, and you can watch them beat. And so let's go. And so let's note left ventricular hypertrophy. Look at the prominence of this papillary muscle. Look at the cavity. This is a small cavity. The left ventricular volume during end diastole is basically markedly reduced. Well, what about systolic volume? Well, look at this. We've got an ejection fraction over here of 100%. That means we're totally obliterating this cavity during systole. And so this ventricle is giving it all it's got, Scotty. And so you can see, it's pumping everything out. It's not filling. Look, you usually see sort of over time, you see a graded filling of the left ventricle. Certainly there's going to be a little bit of filling increased, maybe 20% increase in volume with the atrial kick from sinus rhythm. And so this is a remarkable picture that tells us more about the dynamics at the same time when we can look at the coronaries. And we did look at the coronaries, and we did find out some things about the coronaries. And one of the things we found out was a totally occluded circumflex, and we sent him to get a CTO, chronic total occlusion, open it up and put another stent in. That was one of the other activities that happened during this 6-year period. And so I think we were successful in managing this patient non-invasively, keeping him out of the hospital, 2 nights hospitalization each time he got a stent, 1 ER visit, quality of life maintained, saved on medical spending, no bypass surgery, no increased hospitalizations, no congestive heart failure, controlled his blood pressure, very difficult to control with like 7 drugs. I did no harm. He's surviving and has no disability. How long this will persist, as his lifestyle remains the same. I can't get any weight loss and I can't get any exercise. I don't know, but so far I can call this a success. Do we have any questions? Any comments by anybody? Feel free to comment. Okay, well, thank you very much for visiting today. I think this is an interesting case. I hope you have some good take-home points. Bye-bye.